The Village Well Bookstore in Culver City, California presents Community Conversations, COVID Diaries Part 1, Lessons from the California Trenches of a Global Health Crisis, with Dr. Christopher Lau from Northeast Community Clinics, KJ Page from Chaparral House in Berkeley, California, Dr. Oliver Brooks from Watts Healthcare, and Jerry Seelig of Seelig and Kussage. Learn about the changes to the front lines of our healthcare system and what's next for the rest of us from these most informative and inspiring panelists. Enjoy a great conversation.
Dr. Oliver Brooks has been with the Watts Healthcare Center since 1989. He was appointed medical director in October 16 of 2016. He has a distinguished career as associate medical director, chief of pediatrics and adolescent medicine, and medical director for the Jordan and Law School-based wellness centers. He's the chairman of many quality management committees in the healthcare setting, and he's taken what was a volunteer-driven healthcare clinic birthed out of the Watts riots in 1965 to serving the most in need in LA County, and he is a federally recognized and award-winning healthcare institution. He's been on executive committees of hospitals, and most importantly, he was elected to the office of president of the National Medical Association, which is familiar to many of you and is the largest and oldest national organization representing African American physicians and their patients in the United States. Dr. Brooks holds a degree in chemistry from Morehouse College and a medical degree from Howard University. Chris Lau, who I must disclose, is an old friend of mine, and one of the many physicians and attorneys who reminds me of how I cannot practice law and medicine without a license, and has been a great teacher to me in many of the issues surrounding community medicine. Chris is a graduate of USC and the USC Irvine School of Medicine, and he wants me to remind you he's also a martial arts instructor, which worries me since we dine frequently. So if I get this wrong, I might be in trouble. He runs a great workplace. He's a practicing physician still at the Northeast Community Clinic, which has approximately 40,000 to 50,000 families enrolled in managed care. Chris came to the Northeast Community Clinic early in his career, and he's built it into a highly innovative and one of the best, along with Dr. Watts's institution, community clinics. And they stretch from Alhambra to Harbor City and provide quality care to multiple communities in the city. And I'm then turning last but not least, and we'll speak to us first, to KJ Page, who's a licensed nursing home administrator, a registered nurse, board certified in gerontology, and she meddles in the lives. She says this is her bio. She meddles everywhere at Chaparral House. She also serves as an educator to young and up-and-coming administrators. She runs let me take a step back and then keep moving. I spent a lot of my life being quoted on the front page of newspapers around the country and deep in the newspaper about bad nursing homes. But I'm also often quoted, and we find KJ quite a bit on the front page of newspapers across the country because of the high quality of care she's delivered to Chaparral House, and she'll talk a bit more about it in Berkeley, California, and the innovations she's brought there, and the quality of care, and her ability to work to protect her residents and staff in the COVID crisis. So let me get to the panel. Someone on the Zoom reminded me this morning, it usually likes to go unnamed, that there's a great phrase we have in public policy, no crisis should go unused. So we find ourselves today perhaps towards the end of what has been a war. That's why we chose the words from the trenches of the COVID pandemic. And we have three great people who battled it. We're not here to tell war stories. What we're here is to hear how people reinvented their facilities, how they provided safe care, when their training and their practice and their staff failed them as leaders, and how the staff and they bounced back. So we have the lessons to learn. I'm going to first turn to KJ. Long-term care, as opposed to community health and medicine, was a failure. It is a trusted resource both to us who have family members in long-term care facilities, for those of us who have a hip surgery or get in a car accident and go in for a short stay in what's called skilled nursing. And the tragedy is that 32% of the COVID deaths in the United States, approximately 180,000 souls, died in skilled nursing. For 4% of the population that got COVID, they were the most likely to pass away. At Chaparral House, I believe there were only 4 cases during the COVID pandemic and 0 deaths. So KJ, most people know about nursing homes. They visited them. They may have a family member in them. They may have been there post a surgery. But talk a little bit about everyday life in Chaparral House, and who are your residents, and how did you do so well? And you're a modest person and a teacher of administrators. What did the others do wrong? So take it from there.
Thanks,
and
Jerry.
It's an honor to have you with us.
Thank you so much. Thank you for inviting me to be part of this august panel. So those of you may know that long-term care facilities are arguably the most heavily regulated of all jobs, of all organizations in the country. There's some discussion that perhaps nuclear power has more regulations, and in California, pest control may have more line items. But there's about 1,500 different specific measures that we have to follow. And so any of them that go wrong could be devastating to the residents in our care because they're frail elderly for the most part. Our local disaster coordinating groups in the city and the county of Alameda and the city of Berkeley before the pandemic. So we had quite a stockpile of supplies. My director of staff development, who is my disaster preparedness guru, and I are pretty paranoid to begin with. So we already had quite a few masks and gowns and boxes of gloves just in stock that we were preparing for a bad thing. And when the bad thing happened, it took us about 2 weeks to run through our supplies. Whereas everyone else was still scrambling to get them, by the time we were done completely and we had to call the county and say, what are we going to do? Supply chains were getting back into normal again. So that was the first thing that happened. We were gobsmacked by the fact that we couldn't just call up our med supplier and say, we need 3 more extra cases of masks. We need 6 more cases of gloves. They just were not available anywhere. The other thing is that people live together in close coordination in long-term care. And we always have a joke at cold and flu season. Many of our folks with dementia don't know to cover their mouth when they cough or sneeze. And it's kind of funny because that's the whole education for the staff, is cover your mouth, wash your hands. And these are folks that couldn't do that. So automatically that increased the risk before it even got to staff. So we already felt like we were starting off in a bad place to begin with. The other thing that really got us was Berkeley is one of 2 cities in California that has its own public health. The county had its own public health, and then the state had public health, and then the CDC was issuing guidance, and the Centers for Medicare and Medi-Cal, which regulate nursing homes federally, was issuing guidance. You would think with 5 or 6 people giving you what to do, they would all be in alignment and you would know what to do. That was not the case. Very often, what the federal said conflicted with what the state said, which then didn't match with what the county said and didn't at all agree with what the city was saying. So then we had to follow the most restrictive. And when you have an 11-page guidance, it's not really guidance at that point. And then you have to parse out what works and what doesn't work. So it's really been difficult. We, quite frankly, don't feel like we're at the end of the epidemic. I had a positive staff member come up with, he was fully vaccinated and he tested positive. So we are still in reactive mode. We just came out of that this week, no positive cases, but still in a fully vaccinated person. All of my staff but 5 are fully vaccinated. All of my residents but 1 are fully vaccinated. So we were thinking, okay, it's time to write the after action report. It's time to start thinking about next steps. It's time to get back to what's going to be normal. And then here we are, fully vaccinated, positive. So we're back in the trenches again, back in the everybody gets tested every week, back in the panic, back in the waiting to see what's going to happen next, how many are going to be positive. So it's kind of hard for us to see what's at the end. Our new normal is everyone wears a mask, everyone stays apart. If you're vaccinated, you can hug or you can share a meal. And then there's always the operationalizing that. How do you know who's vaccinated and who isn't? And then how do you keep them from being bullied by other people that aren't vaccinated? So I'm not really sure we're ready for a new normal yet. We're still trying to climb out of the foxholes and the enemy's still shelling us.
Okay. KK, thank you. And I must add, even though she used the war metaphor, she is a woman of peace and has overcome all these challenges. We're going to come back to some of the innovative things that you've done, KJ, like vaccinating family members and convincing staff to get vaccinated. I want to turn to Dr. Brooks. Dr. Brooks, you're part of a highly trusted, little-known organization called Community Health Centers. Even the Republicans in Congress love the federally qualified and the rural clinic system. And you, for the most part, as providers, have done a damn good job and responding to a challenge. So tell us a little bit about the Watts Community Clinic, the neighborhoods you serve, and why it is you were successful, the greater you, your team, you're supporting hospitals. What were the long-lasting inequities, and how did you overcome them? And what's the next, once again, war metaphor, what are the next battles? So I'm going to leave it to you to tell us a bit more about Watts, your career, and the challenges you faced and the challenges you overcame.
All right. Well, thank you very much, Jerry, and thank you for hosting this forum through the Village Well books. So we're in Watts. Watts is in SPA 6, which is how the county is divided up in terms of service areas, service planning areas, in terms of designation. So it's has the lowest relative income, lowest education, highest rates of STDs, very high rates of cancer, heart disease, chronic kidney disease, and everything you can think of. So that's where community health centers go. Our job is to serve those communities. Statistics show that the outcomes in terms of quality measures are better at community health centers than at private doctor offices very commonly. It's because we focus on that, and that's what we do. So, COVID hit for us in mid-March. The governor put out his safer at home, I believe it was March 13th, and we immediately had to shut down in terms of having face-to-face visits. So we immediately shifted to televisits, and I know Dr. Lau can speak to this also. We had to learn televisits. We were probably doing 1% televisits. We went to 99% overnight. But we did learn, and we adopted, and our patients adopted. A big challenge after that was management of the staff. First, we had to lay off a lot of staff, but as things picked up, we brought them back. Now, as we brought them back, we started having staff with COVID. We were proud to say that of the 54 staff that got COVID, probably only 1 or 2 got it at work. Everyone else was getting it at home. So people were always talking about healthcare workers and the high exposure and how dangerous it was. What happens in the healthcare environment, you focus on infection control, as KJ Page said, and was so successful. I have to tip my hat to her. The death rates in nursing homes and adult care facilities were 400 times the rate in the general population. So whatever she did, and she spoke to some of it, which was be prepared, Boy Scout motto, she was prepared and she saved lives. I tip my hat to you. So then we had to manage staff infecting each other, and then them getting angry at each other and being out. Then how do you manage a department that has 1 person when they normally have 8? You borrow from other departments. So we just managed. It was every day. We would meet literally every day and discuss what the management would be. And then we had to treat the public. So the public were coming in. We honestly didn't see a large number of very, very sick people. But what we had to do is do triage. So let's say 1 out of 10 were sick. We would have to determine that they would be sent over to our local hospital, which is 1.6 miles away, MLK, Martin Luther King Community Hospital. So we developed a relationship with them, the CEO, Elaine Batchelor, the CMO, Dr. John Fisher. So they actually set up tents and had outdoor triage, looked like a mobile army hospital, a MASH unit over there. And I would be over there frequently. So we interacted with them well and had developed a good relationship. And it's interesting because that seems so long ago. Again, what people need to understand, the whole goal of reducing the flat curve, as they called it, was not only saving lives, but primarily to allow the ICUs to handle all the sick people. And so if sick people came in, let's say 6 a day instead of 20 a day, you could handle that in an ICU. And so we were more or less successful, though I will say there were some dark days from about mid-October through the surge that we got after the holidays in January. We made it through. I agree with KJ, where or not, where I've been saying I was saying back then we were in chapter 3 of book 1. So now I believe we are about chapter 6, halfway through chapter 6 of book 1, because there will be a book 2. So now the primary focus is vaccinating. So we got vaccines from the county, and our staff were the first ones to get vaccinated, and everyone got vaccinated that needed to. My biggest disappointment right now is I literally had an employee that I had to clear to return to work because she was exposed. And I said, well, you're not vaccinated? No, I'm not vaccinated. I said, well, do you plan to get vaccinated? I don't know. So I think KJ, she had a higher success rate than we did, but it's really frustrating because the states has mandated 2 weeks of leave for anyone having to deal with COVID-related illness. And it's frustrating to me that someone can be not vaccinated and then get 2 weeks off from work because they got exposed. I mean, to me, I agree with giving people time off from work, but it should be because something happened unforeseen, not that you're unvaccinated and you exposed yourself. We are working now to vaccinate the public, and I've been working hard on that. I was co-chair of the COVID-19 drafting guidelines work group, which the governor appointed to make sure there was equity in vaccine distribution, allocation. The mantra was transparency, safety, and equity. This was led by Dr. Nadine Burke-Harris, our Surgeon General, great pediatrician. So in the beginning, everyone wanted the vaccine. There wasn't enough. So we fought through that. Then suddenly, there's plenty of vaccine, and now we got to convince people to get it. So right now, I am working hard to dispel the misperceptions. Infertility. There's a microchip in the vaccine. It's being used to depopulate the Black community. The vaccine gives you the disease, all these things that I've been hearing. So I'm working hard to dispel those myths. And then the new normal, well, we don't know. We just don't know. So we're making it up as we go along. This is they call it a novel coronavirus because it acts unlike any coronavirus we've ever seen. And so what I believe the new normal will be is we're going to get close to herd immunity, because right now the statistics show there's about 20% of the population that refuse to get vaccinated or only will get vaccinated if it's mandated. That at least gets you to 80% or so. And then some of those people that don't want to get vaccinated, they're going to get COVID. So they're going to have they're going to confer some immunity, natural immunity. So we're going to get close to that. What we're going to have is we're going to have some mandates for people that are unvaccinated to continue to have to wear masks. And I do believe it's going to end up being a vaccine that you get annually, somewhat like the flu vaccine. But again, that's book 2. And that book has not even been written yet. But I'll be first in line to buy it at your bookstore when it is. You're muted, Jerry.
Chris, good thing you didn't hear my critical comment towards you. Northeast Community Clinic, sort of like a gerrymandered congressional district, extends from Alhambra down to Harbor City. Tell us a little bit about how through or adjacent to Dr. Brooks's areas, but a bit how Northeast Community is unique. And I think we can jump a little bit backward into some of the innovative things you've done there and some of the innovative things you're doing now. And then we'll perhaps return to the book we're going to write. But take it away, and feel free to riff in any other area other than USC football.
Well, thank you for having me. My name is Dr. Chris Lau. I'm the Executive Director of Northeast Community Clinic. I've been here since 1995. So had a few years under my belt working here. And as part of our really stellar team, we've grown it from 1 clinic now up to 16, covering initially the Highland Park area near Pasadena, now covering all along the 110 and the 710 corridor that goes all the way down to Wilmington, South Bay region. We typically see about 170,000 visits a year to about 46,000 patients. And we've been doing, community medicine for over 50 years now. So this will be our 50th year. And, what's nice about having longevity in any organization is that you get to see repeated patterns and you get to kind of deal with them proactively and preemptively. And I think that's where Northeast had a little bit of an edge of having a team that's kind of been here. I agree with the term that was given by KJ about the word paranoia. We believe in paranoid thriving. We believe that you have to be paranoid because if you're not, then other people will not. And when we get too comfortable, that's when all of these highly communicable diseases come into play, whether they're highly infectious and highly communicable versus not that communicable, but infectious, but have an extremely adverse outcome, right? Then that would be like Ebola or any of those hemorrhagic variants. During the COVID period, we did lose about 40% of our staff. They went on leave. There was these benefits time. I mean, I kind of mirror the same comment, which is you're trying to do all this hard, good work, and then you got a staff that's almost 50% depleted. And everyone's working literally 7 days a week trying to just kind of get it by because we're now taking call We literally seen patients on telephonically and telemedicine on the weekends and evenings. But we knew we had a higher calling. It is what it is. We just did it. I mean, it just wasn't one of those things where there was time to really kind of ponder whether we should complain or not. It was just a duty we had to perform. Our early interventions included, isolation tents, but we immediately switched over to trailers. We eventually found whatever trailers we could. We called toy haulers, stripped them out, and put on some sealed flooring, whether it was vinyl or otherwise, and was able to do infectious control and see patients before they entered our facilities. And I think with that early screening outside and those treatment centers that are outside of the building, that helped reduce our exposure for our patients as well as our staff. And I could still say with every one of our quality assurance checks on everyone who ever turned positive, whether it's a patient or staff member, not one was attributable to someone at Northeast giving it to someone else. It was usually, again, done like the Watts Foundation was done on the outside. They went to a barbecue. For some reason, barbecues were infamous for spreading COVID. And we would hear that over and over again. So, with that early intervention, that really reduced our number of cases in our organization. We also did aggressive infection control. We went out and bought every alcohol 5-gallon that we could find across the United States and actually made our own sanitizer. We found every quaternary ammonium we could use to spray down, whatever technology we could, electrostatic sprayers that we bought from Georgia to spray down rooms and spray down our trailers right after each contaminated confirmed case or suspected case. So we were really trying to go on the edge of trying to figure out what was the latest infection control processes that we would adopt early on. Another challenge we had was the PPE and supply procurement. I mean, a lot of it was depleted by the time March came around because it was just as fast as toilet paper was being pulled off the shelves. So were the Tyvek suits from Home Depot. We called a lot of the vendors we normally did. They were all sold out. Any new vendor would say, because you're not a current client, we couldn't sell to you. We had to get creative. We had to go through our contacts in China to try to ship them onto containers, onto planes. So we did whatever we could to make sure that all of our staff were protected. But I think one of the challenges we had was either lack of information or misinformation. I think that for us as an organization, early on, when CDC made the comment, now we're not being critical of the CDC as it is that they did wrong. I just believe that there was possibly a breakdown in communication of the understanding or the message that was going out. I think fever, cough, and shortness of breath for us was not good enough. I think that was what was being told at the very beginning. It says that's COVID. And we said that that's not COVID. It goes anything resembling the flu for us was COVID. Body aches, vomiting, diarrhea, fever. We just threw anything that resembled flu-like symptoms as if they were COVID. And I think that was one of the other things that we did that would mitigate the number of transmitted cases across infected people with other parties. So, we always tempered our understanding of what CDC had recommended, and we always took it to the next internal review inside the organization and figure out what made sense. And if we need to be even more aggressive, we did so. We did some things that were off-label. I know when there were early discussions that people's lungs were drowning their own fluids because there was so much inflammation. Now we know that it was like a storm, right? It's a inflammatory storm. So we started giving oral steroids, the dose pack steroids, prednisone, as part of the early intervention before we sent them to the hospital. So we had to kind of make our own decisions as we went along and kind of internally come to a soul searching what we thought was reasonably appropriate and what we needed to do tackling what we had in front of us. And luckily we've done all right. And like the rest of the people who put their lives on the line and those who put their families on hold just to make sure a whole world was taken care of. I think it brings awareness of our role. It's not just generic healthcare; it is life care. We're helping people sustain their lives. In terms of how our practice of medicine changed, of course, now we have telemedicine, and that seems like it's going to be part of how we're going to be doing business. And the vaccination, that's going to be a big key. And I agree that the vaccine is the way to go. We've currently given over 13,000 doses to date. We just had an event with LAUSD, one of our school-based events. We had 909 on that day, and we had about 300 from now kids from 12 to 15. So we are getting engagement from the community. We were a little concerned that we were going to have parents apprehensive about injecting a unknown, in their eyes, vaccine into their children, but we are seeing community engagement. I think this comes from, again, and Dr. Brooks referred to educating, and we hit the same barriers or same challenges that we had giving it to the adults. Again, saying that they couldn't drink alcohol, it would make them sterile, they wouldn't be able to have children. We've had some things that we would find really amazing to hear, but we had to dispel some of those myths based on science and not just based on hearsay. We also believe the new normal would include vaccinations annually, just as it starts preparing for the variants that can evolve. This is a virus that evolves, like all viruses. It wants to survive. So it will continue to evolve to survive. We will also be adopting masks. I know that as a culture, United States culture, you go to the Eastern countries, you see people wear masks all the time. And for them, it's normal. They see it and not as a way of protecting themselves from other people, but it's the other way around. They see it as a social responsibility to protect others in case they're sick. So I think that we're seeing that shift into wearing masks here in the US, a accepted way of socially being appreciative of the others, right? And also early on in identification and intervention of respiratory infectious disease. We are now permanently not allowing anybody with flu-like symptoms, including fever, to enter our facilities, so that it doesn't affect our pregnant patients, our children, our diabetics, our frail and elderly. So all those patients will now be treated inside our permanent trailers, which is part of our mobile medical program. So each cluster and each clinic site that has the space for it has a mobile trailer specifically designed for treatment of patients. And in the future, again, it's telemedicine, telehealth, trying to prevent that unnecessary visits that expose them to other people that are sick. And I'm going to kind of end it with the question is, I was asked over and over again, goes, what's the new normal? What comes after this? And I said, well, now that we have testing for coronavirus, now coronavirus has been here for a while. I think it's been here for a while. I remember getting something about 40 years ago and lost taste and smell, had the flu, out for 3-4 weeks. And I think it's just been around people. It just hasn't been really identified because there was no testing for it. We have a test for flu virus, but before 2020, we didn't have one for coronavirus until COVID-19 came around. So I think that we're going to see the number of deaths that have been averaged over a 10-year that came from flu based on CDC's numbers at 35,000 to be higher. I think we'll see a gradual decline, but we are going to see a number of COVID-related mortality tied into the overall flu-related deaths. So that's going to be part of the realization that it will stick around for a while, and that vaccinations are the key, as well as herd immunity is the key to getting under control. I don't believe eradication is as likely. I think just like the flu, it's about how to live with it and how to keep it tempered and try to protect as many people as we can.
Okay, I'm going to jump in with a book, and that is Michael Lewis's new book, available at Village Well and your local independent bookstore, because we believe in those too. The new Michael Lewis book, Premonition, which focuses on the CDC, and it is the big picture book that we haven't had That is, how did government systems and bureaucracies fail us? We still don't have a book. Well, we have this recording to talk about everyday life. That's probably coming down the line. Also, I want to say we've dropped charts that Rebecca and Jerry, and most importantly, Rebecca's teenage daughter, Evelyn, have prepared. And I think it's worth taking a look sometime or another at where we were on March 16th, data lags a day, of 2020, where we were at a date I picked, January 16th, 2021, which was close to the peak, and then where we were yesterday as to deaths, cases nationally. We also have some data on the state, and we have some great data on the county. And the county data is obviously offers us a look into the drastic failures of a greater city and county to protect the elderly, those in nursing homes, and minority communities. Enough of that. All right, I'm going to throw the. Oh, we're begging you for questions here. My colleague Rebecca Anderson. I see multiple family members and colleagues in the online, and Jen has only known me briefly, but if we don't get questions, it gets very dangerous if Jerry becomes the question asker. So let me ask this question, which was originally in our panel package. What would the book you write, Doctors Lau and Brooks and Ms. Page, RN, write about the pandemic be called? So we're looking for a short answer, and a short answer that's, I guess, a parable. So I'm leaving it wide open, and I throw it to the room. Chris, you spoke last, so I'll let you go first on this. And you're muted. You're muted.
Sorry.
I would say paranoid. Having that paranoia, that the thing unknown coming around the corner, being prepared for it.
So would it also be how I survived more than normal paranoia? Or how I finally learned to use paranoia and love it? Okay. KJ, what would you call the book?
So my book would be called We Have to Do What Now? Because almost every day we had to do something, and most of it didn't make any sense, and we're scrambling to do what we're told and make sense and then explain it to everybody else. So we have to do what now? That would be my book.
I really want to underscore that. I spent the first 2 months, as the boss of 2 nursing homes, one of which had 20 residents on ventilators. And I just have to underline, I would have been probably committed to an asylum that allows you to take your iPad had I stayed much longer, because what you're hearing from our panel is correct. If you were operating in Berkeley or Pasadena or LA, which has its own county health department, you were getting often good, as best as they can do, information from the county health department, then from the county as a regulating body, which in LA does regulation enforcement. Then you've got the California Department of Public Health. And then you've got Region 9, or the Centers for Medicaid and Medicaid Services. And you have the CDC. I survived it because I have on my team a brilliant young infection control nurse who never sleeps. So I could walk in at 7 a.m. and have a briefing, and I'm no exaggeration here, from each of those bodies, often conflicting. So I just want to underline what has been said by all three of our panelists. And I guess the new normal as professionals might be a work in those state and federal agencies to learn how to speak in a clearer, less fractured voice. Dr. Brooks, I hope I didn't step on your line for your book title.
No, you did not. Making sure I'm unmuted. Yes. So my book title would be The Unmasking of Inequity, COVID-19 and the African American Community. When COVID hit, I was president of the NMA, and this all heck broke loose. I wrote an article for the National Newspaper Publishers Association, the African American publishers, and I just said COVID-19 and Blacks. When America gets a cold, the Black community gets pneumonia. And this was in April before all this stuff hit. And so after it's been a year and a month, this pandemic has been devastating on the African American community. Higher rates of death from COVID, higher rates of hospitalization, lower rates of testing, poor preventive care. I want to say the work that Dr. Lau's doing up there in Northeast Valley is just excellent. I admire what they're doing. But my primary focus was on population-based, the macro view, as opposed to the micro view. So I had to live through that. And we are even now focusing strongly on the inequities that still exist. So the unmasking of inequity.
Three great books. Becca and I have many friends in publishing in New York. And Rebecca is an excellent editor and ghost author. And I'm going to turn to her because we are getting questions. The fear of Jerry brings questions. Rebecca, take it over.
So a question for the panelists from Alex Seelig. Assuming telemedicine, can you mute yourself? Assuming telemedicine is here to stay, what are the biggest technical hurdles for telemedicine going forward? So you can all answer that if one of you feels more passionately, but for sure I'll jump in.
So let me just
turn
say,
to Chris, because Chris and I and my wife are working on a teledermatology project, and Chris is probably my hurdles guy or my hurdles overcomer.
Well, and there's a follow-up question, say that another from a doctor in the audience, Dr. Julia Alexander. She says, I know the providers had to learn telemedicine on the fly. How well did patients adjust to telemedicine? So you could probably answer that question jointly as what are the biggest technical difficulties going forward? And then how are patients adjusting?
Jerry, do you mind if I jump in?
Go on, Dr. Lau.
Yeah. So, with telemedicine, yeah, it was for us. We did it. But once COVID came, we discovered we did not anticipate. Some of them were obvious. You examine something remotely through camera. We had to field it, had to examine. That was going to be very challenging. So you had to make your best guest experience and based on what you saw and best way that the images were transmitted back. But those were kind of known challenges. The unknown challenges were how the dynamics of the visit went. When patients come to the doctor's office, they're inside that system kind of moves that around and that timing and everything. When you call a patient at home, you're no longer in the clinic settings realm. Now you're in their realm. And competing things like, making lunch for the kids, going to the store, or using the restroom, or I'm doing something right now, can you call me back in 10 minutes? The whole mindset that, I'm not in your place to be at your, in your framework. But in my framework, that was the challenge we were having about getting their mindset. This is a real visit. We need to address these things quickly. We do understand and want to respect your time, but we're going to have to do it this way in order to get through it. And so there was a retooling of how providers would set expectations right up front, saying, we only have X number of time with you. We do want to cover these key issues with you. And what would you like to cover at the very beginning? So we set those expectations right up front. And that minimized the time frame that kind of expanded from a 15, 20, 30-minute visit to almost an hour. So we had to relearn how to understand the dynamic in telemedicine that was much, much different than having them inside the clinic.
Dr. Brooks?
Yeah, so, and this is something, and I hope the sound quality is okay. I am of the belief that part of healing is the laying on of hands. Number one. Number two, I've found that the physical exam aspect of the doctor visit is the most neglected. So and thirdly, there's the human to human interaction that you cannot get telephonically or audio video. So my concern is that there's going to be more telemedicine than is beneficial to the patient. Clearly, it's a good thing to have because you don't have to worry about transportation. Again, infection control measures are there. And then therefore time. It's easy to be on time when you don't have to be somewhere. But I really do believe that this is not the way to treat patients. So I would say maybe if 75% of visits were in face-to-face with the patient, and then maybe the follow-ups were televisits. I'm a pediatrician, so maybe that's a little different because I'm used to interacting with the child and the mother and doing a physical exam, and just the whole aspect. And maybe I'm just old and I have set in my ways of doing things a particular way. So there are benefits and detriments. And the technical question, a lot of our patients don't want video. And video is really necessary. But I think that some of our lower income patients, they don't want you to see what's behind them. So that has been a major hurdle. And Medicare is considering not reimbursing you if there's not a video component to the visit. So that is a hurdle for us.
I'm gonna unmute.
KJ, iPads as a substitute for a grandson's visit. All the stuff that you had to do in, I guess I would call it tele-wellness, telecommunications, tele-whatever. Obviously, you were one of the first to find a way to open the doors. But talk a little bit about substitutes and what works and what doesn't work. And is there, yeah, I'll just stop there.
So one of the things we found early on was our medical folks, all the providers went to telehealth like immediately before vaccines and testing, because that's how to keep people safe. They weren't going into multiple buildings, for which I was grateful. But we did find out that the more dementia a person has, the less they're able to engage with a screen. Doesn't matter if it's your son or your doctor, they just don't get it. Even we had some put up on the TVs in their room, they just didn't get it. So that was really difficult. Whether it was the doctor's visit, it took a nurse to go with and help explain and do most of the talking. And then when it was the family visit, we had our activity folks go around and set it up and help them. Oh, look, there it is. And here's your son and here's your grandson. And it was usually staff intensive and very little result from the person. They just didn't feel like they had seen their person. We had folks getting very upset. Well, you're in there. Why can't you come here? And they just didn't get the connection. So it's really, really difficult for my long-term folks. The most advanced dementia were the worst because they need the touch, the laying on of hands. You need a sense of smell. You know, you need a lot of things. And smell in long-term care is essential, not just for hygiene, but the odor of things, whether it's C. diff or a urinary tract infection or bad gums or diabetics. All of that has a different smell that you just miss completely if you're just talking about how do you feel and what are your vital signs. So it's a very nuanced kind of thing. And certainly the screen visits were better than nothing, but they didn't solve a lot of problems for our folks with dementia.
We have questions that do not come out of the Dr. Julia Alexander and Jerry Seelig family, and I'm going to hand them over to Rebecca. Take it away.
Yeah, this is I guess the billion-dollar question is, how do you feel this whole experience will affect your individual healthcare delivery systems in a post-pandemic world? And that's from Mona Cervantes. But how do you think this whole experience will affect your individual healthcare delivery systems in a post-pandemic world? Anybody have a playbook?
Let me just say quickly, our infection control practices have now become so front of mind that we had very little flu at all this year. We had no norovirus. We have had no staph infections. None of the stuff that you usually see, a little eye ick here or there, because people are washing their hands so much and they're sanitizing hands of residents that don't wash hands themselves. So the infection control, I think, is really going to be a long-lasting benefit, whether it's at the paranoid level it is now, where we have paid a person to go around every 2 hours and wash the doorknobs and the handles on things, or whether it's just a more awareness of hand washing. That's all to the good.
Anyone else? Dr. Lau, Dr. Brooks?
I would add that I believe that all crises are opportunities of growth and transformation. They're a moment of revelation. It reveals how prepared we are. It reveals what inadequacies we have, and it really kind of strips it down to the bare layer. And it allows us to embrace what it is and be able to either ignore it or do something with it and bring change that prevents the next one from coming. I believe that this is not the last one. There are going to be more coming. It's just the way it happens, right? We thought H1N1 was going to be the last one. We thought MERV was going to be the last one. We thought, whatever it is the last one, but it'll keep coming back. And I think the more prepared we are by having these events and learning from it and actually implementing change, and that was what we committed to on our policies. All of our procedures were looked at all over again. And again, that same mirrored comment, which was that it caused us to really reflect on putting this as our mindset as priority number one. So it was bad in a way, but it was also great in that it forced us to deal with what things we needed to kind of fix in our healthcare system.
And I'll just briefly add, and I agree with what both KJ Page said and Dr. Lau. That healthcare workers are heroes. We're not necessarily heroes. However, our role is there. We have a certain commitment, and I'm hoping that this will increase the respect and keep the respect for healthcare workers, to me, especially nurses, high, because what those nurses have done and what healthcare workers in general have done has been really, putting one's life at risk for others. And I believe that concept will last. And the other thing is that I've been involved in vaccines for 20 years. I've never seen it on the front page of the paper every day for a month. And so it's raising awareness that people now understanding like community immunity and antibodies. I love the fact that now there's a more general understanding of vaccines, and hopefully it'll be reflective in higher vaccination rates for other illnesses, vaccine preventable illnesses.
I have to point out, perhaps because my colleague David Hoffman, who is a former U.S. attorney, assistant U.S. attorney, and an expert on rules and enforcement and what it is the government does and doesn't do to try to make nursing homes and hospitals safer. We went into this COVID crisis with about 95% of the skilled nursing facilities not Chaparral House. The federal government had mandated infection control procedures, training, a special nurse, and so on. And approximately 90% of the facilities failed. They didn't implement it. It was to be a requirement to keep getting your Medicaid and Medicare funds. And it then became the sole focus for enforcement, not the sole focus, but when a state or federal inspector came into a facility, they focused for the most part on infection control because that was where the breakdown was. And hats off to KJ for getting it right the first time, but also for pointing out that we've tried everything, taking away your license, taking away your ability to bill Medicare and Medicaid, workshops, letters, and everything. And so now we see simple stuff like washing hands and spraying doorknobs having an impact, a lasting impact on these facilities. Another question?
Just one question here, just saying, and Dr. Brooks answered it in the chat, but that, and it coincides with my question, and which is overall communication by scientists and the healthcare community overall. Do you think it was improved through this process, and will it help with the broader vaccination discussion in our society? And Dr. Brooks said yes in the chat. So if you want to answer that as a pediatrician.
Right. Okay. And I think more people will get their children back. More families get their children vaccinated. At least I hope so. But the other side of that is there's more awareness of vaccine hesitancy. There might be people that weren't really hesitant or they never thought about it. And now that it's coming out, well, I'm not really sure. So I think there may be some undermining of vaccine confidence also. So that's going to be in that second book. Once this one, I was always looking at this. There was 3 levels. There was the preparation, as KJ did so well. There's the actual war, which we're kind of on the way out, and then there's the aftermath. And so we're headed toward the aftermath. And I am a little concerned that in the aftermath, there may be a whole new expounding on vaccine hesitancy. So we don't know yet. And that's kind of where my mind is as an advocate for vaccinating, how to direct the discussion as we move forward in a post-COVID crisis world.
I have a gag order for speaking about that last guy and the degradation of science and scientists and physicians in the society for that last year. That was a dark night of our soul. So I'm not talking about that. But Chris, I mean, I have worked in various roles in communities like Alhambra, like Watts, small towns. And in those communities, a doctor and a nurse get a lot of respect. They're the expert, they're the person you listen to. And often those communities, there's someone that you know because of their involvement in the community. But what's your experience? Do you think going forward, you're starting out, I think, or maybe I'm wrong, tell me if I'm wrong, in the communities that you serve with a lot of respect for physicians, will it get even more respect? Do you think it'll be easier to convince people to do stuff? Take it from there.
Yeah, I think that the greatest challenge was that the vaccine technology is so new. But we'll get back to that second. But the first challenge we're having is that they're seeking guidance and getting their information everywhere. And they're trying to figure out who's really telling the truth, right? So when we get to a provider who may or may not know the latest technology on the medicine, on the vaccine, only to know that it has a EUA, the authorization to be used, makes it that much harder. So they're listening to churches, they're listening to their friends, they're listening to somebody who had a reaction. So their information is going to get really cloudy very quickly. On top of that, with that uncertainty, especially vaccinating children, I know I had 2 children. I have a daughter that we had to take one step back and talk it over as a family to say, we don't know. Is this something we want to move forward with? And we eventually said yes, right? But it was a very thoughtful process. With the new vaccine technology that came out, even we as providers, we understand that we actually do a little bit of that kind of work. We've worked with other companies on the vaccines, and with this adenovirus vector using mRNA technology, there was other questions that might be a discussion for another time, as well as using DNA as the substrate for creating the proteins, the eventual proteins for the vaccination. There's some questions about how that works, and there's some questions about what factors that should have been discussed before we kind of put it out there. And I think that just that part of that discussion was missing. Went straight from here's a vaccine, go get it. And I think that part of that education to the providers can also help them feel like have a good understanding of what they're telling patients is, to their best of knowledge, is science, and that do understand it, and that their promotion of that safety is something they feel very comfortable with. But again, we had to go through our process in doing that, and I'm sure all of the providers were probably going through the same thing. So I don't know if that helped, Jerry.
Good. Well, you're all the panel, and since there's a significant number of colleagues and friends and neighbors, all invited to our cul-de-sac called Baldwin's End for their July 4th party. So my questions to, I believe we may be invited to all of your backyards, panelists, but when did you actually think our president came in and basically promised us July 4th, but when did you, in your mind, as a professional and as a dad and as a neighbor, think that you would have a maskless, safe July 4th? When did that hit you? And tell us a little bit about, this is a good feeling story as we enter into July 4th. I must add, vaccine hesitancy now appears to be under 15% in California if we keep going this way. So in combination with, as Dr. Brooks says, people getting this disease and this great low hesitancy rates in the large cities in California, we're sort of heading towards our little community herd immunity. But tell us a bit about when you thought July 4th was really going to be a party and your feelings about that, including your exhaustion to get there. Last one.
Yeah, I'll probably be wearing my mask for a long time to come outside in public. I went to a restaurant for the first time 2 weeks ago, and there were 4 people in the restaurant, not including the cook and the waiter. And so we felt really safe, but it kind of echoed. It was kind of weird. You sort of felt like you were closing the place and it was only 5:30, but at least I could eat out. I was really excited about that. But outdoor barbecues, no, not a fan, not going to take that risk. And I know I own my paranoia. I feel like I'm in charge of the whole building and all the staff and their families and my residents and their families. And I just don't want to be that patient zero that went somewhere to a wedding and got sitting next to someone that coughed on me or whatever. So yeah, I'm going to be isolating myself for a long time to come. Dinner with vaccinated people, but we're going to be keeping our distance and mindful of a brief hug and that kind of stuff for a long time to come, probably.
Because we didn't, the culture of skilled nursing, quality skilled nursing, long-term care, even assisted living, is about building a community. And things like activities for people of all level of cognition and acuity, and dining together, and going to a Dodger game. Talk a little bit about the impact of not being able to do that on your facility, and as well as being able to visit with grandkids and family members and buddies from the Army and the local American Legion post. But talk a little bit about what of that's come back and the sadness that sort of and the impact on care that came about over the last 15 months. You know,
well, it's been very sad not having visitors. I mean, our building, it's small, and so the laughter echoes. When the room is filled and they're doing balloon toss and people are laughing and singing, and that's a kind of a feeling you have throughout the day. And so that wasn't happening. It was quiet. It was echoey. We didn't have visitors everywhere. We didn't have our pets visiting. It was really sad. We actually hired a local psychologist to come in and visit with people on a, 5 people this day, 5 people that day, because we couldn't let their families in. And we felt that we'd have a better shot with a professional who didn't want someone from the resident. It's not like, oh, well, come talk to me about yourself and reminisce with me, and then we'll give you your pills. So we didn't want a quid pro quo. We had someone that was totally dedicated to them. We had to spend a lot more time around meals because, believe it or not, people eat better if they're eating with others when they have dementia. It's kind of a habit. It's kind of a social thing. And so now everyone's eating in their rooms, and that was just totally not what we were about. So we had to spend extra time and extra staff and extra everything to be sure people did not lose weight through the pandemic. And so we had to make sure people were not getting depressed, and we had to spend a lot of extra staff time in that room, engaging them in things that would have normally just been part of their life. They go up in the morning, they get dressed, they go to the activity room, and they spend most of the day there. That was just so sad. They couldn't do that. No hugs. We're a big huggy place in Berkeley, and no hugs. That was really, really sad. I found myself, can't hug you. Sorry. So that's going away little by little now, but it's still very sad, and we don't want that to happen. So we're all very careful that we're being mindful of things so we don't bring that back in.
And it's interesting. We are very huggy people. I'm not hugging people. I'm not even shaking hands yet. But I will say this, I am very comfortable outside without a mask. The virus does not spread well outdoors. And there was early evidence, I don't really know if it ever was verified, that the virus degraded under sunlight, but I kind of believe that a number of factors led it to that. I'm still not ready to go to a baseball game. In other words, a crowded outdoor gathering. But looking at your July the 4th, my thought was Labor Day, just so you know, Jerry. But I am feeling that it's a select individuals or groups that I would hang out with. In other words, I don't know if I'd want to come to your big bash on July the 4th because I don't really know everybody there, although I know you and your family will be there. I'm almost feeling like family already. But for me, I'm looking more like Labor Day when we're kind of more open and I'm more comfortable. And hopefully more people are vaccinated by then also.
100% vaccinated, and we've had our first dinner party, and I'm very proud of the community. We have 3 teachers, we have healthcare workers, and we have a bunch of people who just didn't jump the line, waited until I, as the expert, said, you're not taking this vaccine away from anybody. And Chris helped me a lot with that, and other people I knew. So, yeah, we're 100% vaccinated, and you're still invited. Get a home and away. I can guarantee, and there'll be physicians on the block and attorneys. I can guarantee it, but that means you're the host. So, Chris, what's on the docket of the Lau household for July 4th?
I have to mirror KJ's thing, which is I'm not 100% convinced yet. I just want to make sure because when we're running an organization, we're the person who meets and greets the most people, and we're like the one who kind of is like a pyramid. When you're at the top and you're infected, the people all around you get infected. So we still have that mentality carrying forward until we could see adequate immunization. So for us, we're probably just gonna have very close family coming over. I don't even see my mom. She's 80. She's 86. Yeah, and even though she's got vaccinated, I still am not 100% comfortable. We're still waiting to see how this plays out a little longer. But we are having very close family coming over, but that's about it.
Question?
Any last closing statements? We have an anecdote in the chat about people in Chicago
It's my nephew
behaving brazenly in Chicago. But if you just have any closing thoughts about shots, oops. But we're just really thankful to our host Jen for having us here. And honestly, if you're anywhere nearby, do stop. It is a lovely place to be. One of my favorite places is a bookstore. So thank you, Jen, for having us and hosting this conversation. But we'd love to hear any last.
Yes, we will. This is being recorded. We'll post it if we can on the Village Well. We'll send it to the revitalized list eventually. So it'll be available on our website, thepcos.com.
On which I put if you'd like to link to Jerry's newsletter where he updates weekly, a lot of great writing and great reporting. He kind of culls the universe for you. So that link to subscribe to that is in the chat as well. But that's all I have. Thank you. It was really nice to meet.
And we'll post the books and that our panelists recommended. And okay, so take us out with a happy note, each of you, please, starting with Dr. Lau. That's what I wanted to know.
You're muted, Dr. Lau.
I didn't want to sound like the doom and gloom kind of thing, but that kind of helped us kind of get through where we are. But there is light at the end of the tunnel. I think that we are now getting to the maturation phase of vaccines and kind of vetting the ones that actually make sense and that's the safest profile. I think it's this whole process accelerated our new venture into how vaccines would be used towards other diseases. So it's actually a good thing. It also made us look at priorities that are important to us, family and how we spend our time. And it wasn't so bad to have kids at home and be able to spend time talking to them so they can share stories. So I think that the light on the tunnel is what we appreciated during this and not just the challenges that we suffered through.
Great. KJ, Dr. Brooks?
Ladies, KJ.
Well, I'm thinking if the light at the end of the tunnel is a train, it's at least driven by the good guys. And so we're prepared to duck under the trestle and get going with whatever comes next. We feel like we're resilient more than ever. And I really do like the spotlight on long-term care as much as it's been filled with the horrible things that happen, because now we're finally talking about funding. And if you can't pay a livable wage to someone because your funding, your resources are underfunded to begin with, what good is it? I mean, how are you making money off of a system that doesn't pay their people a living wage? And so I'm hoping that some of that national discussion will actually come into some rethinking of how the funding is done.
And I will close mine with a couple of things. One, Dr. Lau said it in a different way. Blessed are the uses of adversity. That's Shakespeare from Macbeth. We have made a way out of no way. And I keep thinking the first case here that we knew of was January of 2020 in Seattle. And here we are 16 months later on the downslope. So it is a medical, biological, biotechnical miracle that we are able to be here. So I think that it also shows, as KJ said, the resilience of us as a people, as a nation, and as a world. And then we found alternative ways to get things done. So you should have the confidence that whatever comes before you, we have the ability to persevere and to overcome. We shall overcome. And I'm wholly optimistic about that. So that is my close. It's there. The light is shining again.
There you go.
I want to mention each of our panelists are leaders of a 501c3 not-for-profit. And if you feel moved after you've bought your books or before you bought your books, you got to do both. We've got a little bit of National Public Radio going on here, along with bookstore. Feel free to donate. Feel free to look up the organizations and volunteer in some instances. I want to underscore what KJ said. The long-term care industry, you can Google for-profit greed in the New York Times and the Washington Post, the LA Times. There's one or two good legal articles on it, including one by Seelig, Hoffman, and Sis, looking at the impact of the financial model. And most importantly, the commitment by the new administration to look at and then change why we pay skilled nursing staff, home health staff, community health staff, daycare workers, so little money. And now's a good time to start writing your senators and congressmen, and particularly those of you who aren't in California, to start working on the family bill, because that's what we need to change it. And lastly, to take a look at what true community health means, which means what all three of our panelists are doing, and having the resources to keep people at home or to put them in a hospital or get them to a doctor. Thank you so much for joining us tonight.
Thank you, panelists. Honestly, really inspiring, I'm really moved, and I do feel optimistic. Even though the lights went out at the bookstore, it's very exciting. Lights out, but it was truly remarkable. It's great to hear all your wisdom, hard won, and thank you again for being here and sharing.
And lastly, it's a full service cafe with a wine and beer license. So so those of us here are staring at a sign that says rosé, Malbec, and a white Spanish grape that I can't pronounce. Albarino. So stop by. The hours are 8 to 3 Monday through Thursday, and open till 5.
Friday, Saturday, Sunday, we'll be expanding our hours, our weekend hours to 7 soon.
Yeah, weekend hours till 7.
Starting sometime in June.
And thank you to Jen for creating this space for us all to share and talk. It's been really remarkable.
And when you're in Culver City, the first round is on Seelig Kusich. Good night.
All right.
Thank you.
Thank
Thank
you.
you.
Thank you.
Good night.
Thank you.
Good night.
Thank you, panelists.
Good night.